Sorry, I'm going to have to bring up my talk again. Okay, so those patients, the complete response overall was about 49%. 5-year overall survival was 32% in the entire cohort. However, patients who did the best were those who were fit for surgery but refused the radical cystectomy, so they elected the trimodality treatment. Another study from Kaufman, this was an RTOG study, had 80 patients recruited and medically inoperable patients mostly. The response was fairly good, 81%. And they've used paclitaxel to the induction and consolidation of chemotherapy with a better response. However, there were more grade 3 and 4 toxicities. So that was an issue. The prospective multi-institution study from Lagrange, 53 patients had a fairly long survival, 8 years. So 36% overall survival in 8 years. Again, those who were fit for surgery did better than those who were unfit for surgery, 43% metastatic disease. Quality of life was found to be high. Patients for surgery, like I said, did better. Fit for surgery did better. A study from Mitten, another prospective multi-institutional study with the medically operable patients. Follow-up was decent, about 6 years. Complete response was 85%, and near complete response was 15%. Recurrence rate was 34, which is kind of on the ballpark with the other studies, and about 72% complete responders. And the conclusion from that study was that even those with near complete response may be eligible for trimodality. And another study from multi-institutional RTOG, again, they had fairly comparable response rates. Moving on to something that we don't really discuss too much, partial cystectomy, not really traditionally thought of when we try to, when we think of organ preservation, just because older studies had fairly low overall survival and high local recurrence rates, you know, as low as 25 and as high as 78. However, the later series had better selection of these patients. And these are mostly patients with solid tumors, smaller, so less than 5 centimeters. And these series had much better overall survival, ranging from 53 to 70%. However, local recurrence still remains an issue from 18.5 to 38%. One study I'm going to quote is the one from Memorial. This was, you know, the downside of the study was a little bit of a shorter follow-up. It was a select group of patients who had solid tumors at the dome, no associated CIS really at the time of diagnosis. And 67% were disease-free with intact bladder at the time of the paper that was written. That was about 33-year median follow-up. And 55% were continuously disease-free with intact bladder. When they looked at the factors that were contributing to recurrence, they noted that CIS and multifocality of the tumor were predictive of a local recurrence, and positive lymph nodes and positive margins were predictive of advanced recurrence. This is a concept that I actually haven't come across before. I've looked into this a little bit more in detail. It's called tetramodality therapy, so it trumps like any of the other therapies that we've experienced before, obviously. This was from Japan, and they took patients who had maximum TURBT with induction chemoradiation, and they had initially muscle invasive cancer. After the treatment was done, they had a reevaluation with the repeat TURBT. So 107 patients had either not complete remission or some small amount of non-muscle invasive disease. And these were the patients that underwent partial cystectomy. So the rest of the patients went on to have salvage treatment. The numbers for these patients who underwent the tetramodality were quite good. So the recurrence-free survival from muscle-invasive disease was about upward of 90s, 97%. The cancer-specific survival was 93% at 5 years, and the overall survival was 91% at 5 years. So fairly good, although this is not something that we do very much. So the question is, how can we make this a better treatment for our patients? And I think the caveat is that we need some better staging and we need better biomarkers. I don't have a whole lot of time to go into this in detail, but I will, fairly quickly breeze through all of this. So staging. What do we have for staging? So we have the TURBT for local recurrence, and we have a few studies showing how poor this modality is in finding the recurrence of the patient. So this was a study from multiple institutions looking at CT0 patients after the neoadjuvant induction, and 65% of these patients had more than a T1 disease, and 12% had positive lymph nodes. This was a study from our institution at Hopkins, again, looking at the clinical restaging and also tumor sequencing. And that showed that about 32% of these patients were falsely downstaged from the repeat TUR. And those patients from the T2 disease performance characteristic was not quite good. So the specificity was 95%, but sensitivity was only 27%. As far as the imaging, we have a CT scan, which is not a great study. Only correlation coefficient is 0.31, which is a fairly poor performance. We have a PET scan that hasn't been traditionally used too much. So FDG PET is used in smaller studies with the accuracy of 60%, which is still far from ideal. The MRI is more of a newer modality, so MRI of the bladder, assessment of the downsstaging, smaller studies with very heterogeneous protocols, sensitivity 81%, specificity 50%, and accuracy about 69%. So these are all kind of studies that can be improved to help us. So with the lack of good staging protocols, we have turned into biomarkers. And this is just a plot of the mutations from the TCGA data, looking at some of the mutations that have been discussed in the past, but also some of these DDR genes or the DNA repair genes. The ATM was present about 14%, and ERCC was present about 9–10% of the patients with MIBC. So these have kind of become the focus of the newer biomarker studies for the response to chemotherapy. So what do we have for the DDR genes that are actionable? We have the mismatch repair genes, which have traditionally been kind of really implicated in the Lynch syndrome, however present in some of the lower tract urothelial cancers. And the reason we are excited about it is because FDA has now approved pembrolizumab for MMR deficient tumors. Some of the newer genes that have been explored is the ERCC2 and ATM. Both of these are shown in small studies to confer cisplatin sensitivity. BRCA1 and 2 we don't really think about much in bladder cancer, and rightfully so, because they appear to be more of a passenger mutations, because the response to PARP inhibitors has been disappointing in comparison to the other tumors. So we have three trials using biomarkers. Some of them have reported some outcomes, and the other one is outgoing. So HCRN 16257 is looking at ERCC2, ATM, FANCCRB1, and TMB, giving GC and nivolumab. Retain is looking at ERCC2, ATM, FANCCRB1, and giving dose-dense or advanced MVAC regimen. And the ongoing Alliance trial, A031701, looking at quite a few genes, and the therapy is a dose-dense GC or just regular GC. So very briefly, so the HCRN 16257 ended up recruiting 76 patients. Out of those, 31 patients had clinical CR, 30 patients had no cystectomy and received nivolumab for as a maintenance for 4 months. Complete clinical response rate was about 48%. When they analyzed those patients who had clinical response, I found that the associated high tumor mutational burden or the presence of mutated ERCC2 were associated with clinical response. The RETAIN trial, which has multiple arms, again, patients were enrolled from first TURBT, the tissue was obtained for mutation analysis, then they had the advanced MBAC, went on to TURBT number 2 when there are no residual tumors and the positive mutations when enrolled in active surveillance. When there was a superficial tumor, mutation negative, they were given the option for any of the 3 treatments, intravesical therapy versus chemo-RT versus cystectomy. And those with CT2 and higher had the option of chemo, RT, or cystectomy. Analyzing the results of the RETAIN, so there were 71 patients with intention to treat. Bladder preservation rate was 55% intention to treat and 89% in patients who actually went on to the active surveillance. Alive and metastasis-free survival was fairly good, between 86 to 90% when looking at the population for intention to treat and those who were actually surveilled actively. The conclusions from this, really the only biggest predictor was the mutation of ERCC2, and that was predictive of the lower recurrence. So the ongoing trial, that is the Alliance trial A031701, is recruiting patients with CT2 and 4 and 0 cancers, and investigators' choice of chemotherapy, whether to give dose-dense gemcitabine and cisplatin versus the regular, and looking at the DDR alterations, those who will have a clinically complete response or CIS will go on to continue to have bladder-sparing protocols. Those with T1 or higher will go on to have radical cystectomy or chemo-RT. And DDR wild-type patients will go on to have radical cystectomy and chemo-RT. So we're anticipating results of these, this study. So to summarize, and the conclusions of this talk, bladder preservation is an alternative to cystectomy in a very select patient population. What we can do better is improve the staging to help with the patient selection. And there are multiple trials utilizing biomarkers, and so far from the genes, the DDR genes hold promise, but they're still not ready for prime time. And this concludes my talk. Thank you very much.
Great, thank you very much. Let me get back on view here. That was wonderful, very thorough. I know I have a question about the biomarkers. So do you think that we're moving in the direction that, or the hope will be that the biomarkers will really be used mainstream, much like for advanced breast cancer? You already mentioned the BRCA gene and those kinds of markers. Is that where we're really moving for diagnosis or for staging of the bladder cancer?
Yeah, I think so. I think, especially with the judicious use of chemotherapy ahead of time, it's very important to identify those patients who would be more cisplatin responsive. And I think we're underutilizing the markers. We don't have the good markers yet, but I think, eventually, maybe in the next 10 years, it would be nice to have these.
Yeah. And it was discouraging to hear the data on the second look for TURBT in the tumor bed, and you get this false sense of assurance that there's no further tumor that's there. And there truly really is have really great ways to look at that any other way, as you showed. I don't know if you can comment a little bit more on that, and do you think that we should still be doing the second aggressive TURBTs in the tumor bed to try and see what's there versus doing random biopsies around the bladder, or how should we be trying to stage them in a better way and identify those who've gone on to muscle invasive?
Yeah, I think, the key is to, so what this actually speaks about is for patients to have false sense of security. If you go on into a second TURBT, and then, you don't find anything and the patients are great, I don't need to do anything else. And I stopped doing it personally in our institution as well. We've stopped doing these repeat TURBTs before radical cystectomy. I think for organ preservation, absolutely yes. We should go on and do a very aggressive TURBT. I heard a talk from Harry Hurd not too long ago, and he was kind of showing the pictures and, of doing like the super aggressive the TURBT at the posterior wall because he can get away with it. He was saying, at the bladder, dome, and anterior, just go on and do a partial cystectomy, just because you're not going to be able to get a really good staging TURBT elsewhere. So yeah, I think it's a role for it, not in the routine pre-cystectomy setting.
Yeah.
So I have one more question, Suzette, if you have done.
Please.
Okay, thank you, Armin. It was a very beautiful talk. And I would like to ask you about the trimodal therapy. I know that it's gaining more and more importance in the practice of certain countries. So even though we don't have enough data to really assess the efficacy of this way of treatment, what do you think? And what is your response to those who think that surgery is not above the trimodal therapy? And second question is about after cystectomy. Do you have enough experience in using salvage radiotherapy and chemotherapy after having done cystectomy and realizing that you have some residual tumors there or a positive lymph node?
Yeah, so for number one, I think, the acceptance of trimodality therapy in urologists has been much lower than it is for patients. I think, we never really trained to discuss it with the patients, but I think, with the data that's coming through now, with much better, survival rates than they were before, and better radiation and better chemo regimens, I think, especially with patients with the smaller tumors, I do discuss it routinely with them. So I think it's at least an option that they should be aware of. The downsides are obviously, it's not like the surgery is going to be more difficult after the TMT. However, there are some certain limitations in types of urinary diversions that they can or cannot get afterwards. So as long as they understand that, I think it's a very reasonable thing to try in patients with small tumors, limited tumors, and no CIS. As far as the utilization of radiation after cystectomy in high-risk patients, I think there was a trial then, and I don't remember I don't remember the results of it. There was a R2G trial that I think it closed off because of the low accruals of patients, I believe. But I think there are certainly, especially with some variant histologies such as squamous cell, positive margins, definitely radiation is something that should be utilized a little bit more. And, they routinely go on to see a medical oncologist with the higher stages regardless, even if they've had a neoadjuvant chemotherapy with the newer, trials and the medications that we have in the adjuvant setting.
Great. I think it's a really good option, just if I could mention in terms of in UK, if I talk about my my center, my colleague who does mostly bladder cancer, muscle invasive. So he's gradually turning towards using multimodal therapy, bladder preservation, especially patients who have relatively less life expectancy. And we don't have a large series, but it's still bladder preservation with the partial cystectomy especially. I think it really buys them time and avoiding a major morbid procedure like radical cystectomy with Ndoye or new bladder formation. So that's absolutely the way I think we're going forward.
Mm-hmm.
Okay, I think then that wraps up that first half of our program here, talking about bladder cancer. Thank you very much both to the speakers. And we will move on to the next topic, which is looking at prostate cancer. I have the distinct pleasure of introducing our first speaker in this area, Dr. Evelyn Mshakoa from South Africa. She's a true trailblazer for women, for sure. She became the first Black woman to qualify as a urologist in South Africa, and she's worked very hard and used that platform to advance her own career as well as that of others. She's been in practice for more than 23 years and used that experience in the field. Currently is at the University of Pretoria in South Africa, and her training was in South Africa as well as in France. She has a Bachelor of Medicine as well as Bachelor of Surgery, a Master's in Urology, a Fellowship in Urology, specialty training in laparoscopy, And then most recently, she's now a registered urogynecologist, which she completed in just 2020. She is definitely a urologist, an educator, a researcher, a highly regarded locally, nationally, internationally by the urologic community. She's very passionate about urologic oncology, of course, as well as reconstructive surgery, and is finalizing now her PhD that focuses on both reconstructive surgery and prostate cancer treatment. She's a very impressive woman indeed. Dr. Moshe Koa will talk to us today about prostate cancer and looking at more of that patient-centered approach to the management of low-risk prostate cancer. So with that, I will pass the floor.
Unmute myself. Suzette, thank you for such an impressive introduction. I felt like you're talking about somebody else. But anyway.
It was easy. It was easy for such an impressive woman.
Yeah, but anyway, I'm trying to get my presentation here. Go to my slideshow from the beginning. Are we good? You can see my.
We can see you, but we cannot see. It's not changing into the slideshow mode. Maybe at the bottom of this screen, you can see that slideshow thing next to 48% where it's written. So maybe it might just.
Next to?
Where the 48% is just next to that, the icon. That might bring it to slideshow mode.
Yes, I've got the. It says your screen sharing.
Okay. Great.
Let's see the no share. And then share.
So you are sharing, we see your slides, it's just not in slideshow mode.
Oh, it's not in the slideshow. What am I supposed to do here?
So
can you go back up to the top where you were? It says we're from the beginning.
Okay.
Can you click on that?
What do we see now?
The same. You don't see it in slideshow mode.
I'm gonna stop. Hi, this is always a problem when I'm presenting, that something goes wrong.
no, that's okay. Just screen share again.
Share the screen.
Yeah.
A slideshow from the beginning.
Yes.
Is it fine?
I think you can still do it that way as well. But if you look at the bottom of the PowerPoint where the percentage is written, 48%, can you see that on your PowerPoint just at the bottom?
Where it says?
48%, there's 48% written, a number. Just next to it is an icon. If you try pressing that, maybe.
Arrow, highlight. No, I don't. My screen is completely 100% on.
Okay. All right.
But I want to. I'm seeing the whole screen, like the whole slide here.
I don't know, Evelyn, you can still present that way. Maybe just change slides. I mean.
Okay, let's see.
Let's see.
I'm on the. Let's go. You can see that now. Anything? I've changed the slide.
Good evening, Prof. I think if you stop sharing and then start sharing again, and not put it on full screen, I think if we just switch the slides in this mode, the non-full screen mode, I think we will see it. I think there might be an issue with the graphics card. I saw there was an error initially with some graphics card error.
I must stop share. I'm stopping the share.
I think just try share again.
Okay, trying to share again. Yeah.
Okay, getting your screen. I think maybe if you go to
Oh,
slide
I
2.
see where it says 48%. I must
Um,
open the whole day.
No.
I
200.
think,
No. Just make it 48% again. What I mean was that the icon just next to it.
Oh, there.
No, just next to it, very next to 68%. The very first icon. Just go back again to right.
To
No,
not to.
other way around. That's next to where 68% is.
Okay, there.
Yeah, this one just
Slideshow.
unless Sanjay, were you going to advise something else or?
so yeah, I was just suggesting maybe we can do it on this mode and then go, press the down arrow and then across the slides without full screen mode, because we can still visualize it quite clearly.
Yes.
Prof, is it coming on your side?
Yeah, on my side, I can see very well. That's why
I think the error comes in when we try and put it on full screen mode. So if we can stop the share and try resharing one last time, and this time we won't attempt to go full screen mode, maybe we can just skip the slides manually.
Yeah.
Okay.
Yeah.
If you can just click on slide 2 and see if it transitions
Okay.
on the left side.
Slide 2 there. Yeah.
Yeah.
Is it fine?
No, it on my side it's not. Oh wait, it worked. It worked. I think we just have to zoom out a bit.
Yeah.
If we.
Yeah. Just press this negative just to make it smaller. Just go to about 50%. I think
That's beautiful.
Yeah,
That's perfect.
like that.
Perfect. Yeah.
Is it fine?
It's looking good. It's looking really good. Yeah.
Yeah, we can still see it. Yeah, please go ahead. Thank you, Sanjay.
Okay, because it says resume slide, so I must leave it like where we are.
I think it might be better just to change the slides without going full screen. I think every time it goes to full screen, it seems to be creating that error.
I think you should tick on escape button to be out of this mode.
Which button is that now?
It's escape. You have escape on your keyboard.
Yeah.
Maybe if you touch it.
Yeah.
You will
I have touched it. Yeah.
I think probably best to just do what Sanjay has mentioned as well. Just keep pressing each slide, and we can still watch. We can still see.
You can feel okay.
Yes, just press 3 and then 4 and then 5, and then we can keep going.
Like that. I'm gonna make it a bit bigger. Is that fine?
That's perfect. Yeah.
Much better. Okay. Yeah. All right. Let me talk about low-risk prostate cancer. Please don't mind my DVT. Whoever you may be having the mic on now, because it's giving me some feedback. I call myself a BBT, born before technology. Some of the challenges that I get. But anyway, let's talk about low-risk prostate cancer. I don't have anything to declare. I'm going to talk about, the approach, which we're talking about now, that it has to be patient-centered approach. And I always say we have to be cool like ice, look at the patients, think of patients' ideas, what are their concerns, and what are their expectations. So for you as a clinician, we will talk of what are the factors that we should look at in our patient. And then, of course, what is screening and diagnosis that one can bring on? What are the treatment options that we have? And of course, that will have an impact on the monitoring. Initially, when I started in urology, because I was seeing a lot of patients coming in, with a cancer that is advanced. I always said a cancer is a cancer, I remember, so everyone who comes with local, you wanna do something. But I realized that no, some of the prostate cancer that we see are actually like what we are seeing here, are like cats, But the cat family is interesting, Sometimes you think you are looking at cats, when it's actually lions. So that's the high risk. But today we're going to mainly look at the cats and how by low risk prostate cancer, which is relatively, your domestic cat. So what is low risk prostate cancer? I like, making life easy, because this is how I usually even sit down with a patient and explain to them that firstly, the PSA level is important, the Gleason score, the clinical, evaluation, whether it's a T1 or a T2. So that is basically what we'll be talking about, low risk prostate cancer. Anything beyond that would be more on the intermediate. And I think also when you're talking about low risk, especially now with the current, pathological classification of, of the Gleason score, we hardly have Gleason 1 and 2 reported, which is one part of the consensus, because it would lead to a lot of, confusion amongst us. What about the patients who are over the age of 70 years? Is it important to include them in this or not? What I should say is, the geriatric score of 8, where you are looking at 8 parameters is very important. Those of you who are interested in, you can go check it on what are the parameters that we look at. But you are going to score your patient. If you score your patient to be more than 14, then it's better to, decide on that no, I can still do something, the patient is fit. But if their evaluation is, actually less than 14, it means they may be either vulnerable or frail. And these are the patients who I will usually, when I'm admitting, I will have a physician on board who will help, to manage the patient. It makes it easy. One doesn't have to be thinking more of the risk factors in terms of the heart, the lungs. The physician will be there to actually cater for that when you are attending to other urological issues. So in screening and diagnosis, what are the significant things that we should look at? Firstly, we know that prostate cancer is worth to be screened, because when you look at the WHO reasons why you would screen a disease, is that firstly, it should be common. Secondly, after you have detected it, you should be able to, offer cure. And that is where the prostate cancer will definitely fall in, because 80 to 90% of men with early prostate cancer can be cured when you give treatment. And that is a positive. I actually always tell them that, wherever you are, we will work with you. So in the diagnostic steps, definitely doing the transrectal ultrasound, guided biopsy, that is my way of doing it. But in the case where I do a rectal exam and I can feel a nodule, practically I will first biopsy, that nodule. I always say, if I can feel the lump, why would I go now with a, with a sonar? I will still do the sonar on the rest of the, but where I feel a nodule, I'll first go finger guided, and then I'll go then use a transrectal, guided sonar. There are cases where one would think of computer-aided tomography, but honestly, in my day-to-day, it's rare for me to have to do a CT scan as part of my diagnosis. MRI, definitely. There are cases where I'll do an MRI before. For instance, if I cannot feel anything and I want to be able to decide. Secondly, patient who I'm thinking there may be a T3, I'm not sure. So I do also an MRI there. Patients who are coming for rebiopsy, find that you've done biopsy without any MRI before, and now their PSA has been going up, and I'm considering to do a rebiopsy. That is when I'll also do, an MRI. In this era, bone scans, I know when you look at for instance, the EAU guidelines, they still have recommendations of bone scan, but most of the patients we have in my space is that we do a PSMA, a PET scan, that makes it easier and is available in cases that are indicated. So we have to basically, for low risk, it's usually, not necessary to actually even go that route. So for the diagnosis steps, the history is very important. checking what is the IPSS score, then examination. All the time when the patient come in, I'll do a uroflow and then do a urine dipstick to check anything like UTI, hematuria, any indication for me, for instance, to consider doing a scope, rectal exam, and then blood test. Luckily these days with our GP knowing what to do, they'll send a patient already having the PSA, and some of them will actually send them already with what they think they found when they did the rectal examination, but I'll still do to have my own opinion. Transrectal ultrasound, only if I'm doing a biopsy, not for anything else. And of course, and the type of biopsy that I usually prefer to do has to go on with the type of, type of the size of the prostate that one is having. Just moving almost about 5 millimeter to decide on that. I don't usually go like doing any prostate study, but these are the basic things are the ones that I just mentioned. So now what are the treatment options that we have? Active surveillance, watchful waiting. Honestly, like I was saying to you now, that if you talked with me 10 years ago about active surveillance, I would be like, no. And then watchful waiting, obviously we know we are looking at relatively older patients who you are watching if they are going to have symptoms. So, but it's important, active surveillance, one of the things that I still have in consideration is, are the patient compliant or not? Like I said, we need to be cool like ice. We need to know ideas, concerns, expectations. If your patient is very concerned, putting him on an active surveillance protocol may become an issue. You find that he goes actually to the next urologist, for instance. So during the time when we are following the person up, they should be aware of the regular PSA to be done, and there may be a need to do an MRI, and also there may be a need to redo biopsy when you are thinking of maybe there could be up grading or upstaging. And on the treatment options, watchful waiting is usually for elderly patients, as we know. We are thinking of patients who are not really surgical candidates, and then you can monitor, but you're just waiting basically for them. So it's not for everyone. And then what about active surveillance? Actually, now we know that more and more physicians and patients do choose active surveillance. Some of you can, you can actually, one of the convincing trials which is very interesting is actually the pivot trial, which can show how much, when you are waiting for low risk disease, that usually you won't have, you don't have much benefit of surgery in low risk disease, but you have got more complications that one can have. So over the years, it has been shown that, the active surveillance is actually increasing over the years when you compare to radical prostatectomies. I think now because of robotic, definitely there's still a lot of, radical being done, but this just shows you how increasing is the tendency for patients to choose and physicians to choose active surveillance. And what are the benefits of this? There are many trials, which have been done with active surveillance, which do show that, once you decide on doing active surveillance on follow-up, overall survival, it's actually good, in these patients. So it's not something to really be worried about. And also cancer-specific survival. This is for patients who you could have decided they would have decided being on active surveillance, and then with time you decide to do treatment with curative intent. That it's not, this is just showing that on radical prostatectomy, how many would be found on different trials to be having like a T3 disease. But still, at the end of the day, we always look at, overall survival and also cancer specific. So basically, it's almost like delaying to offer treatment, with surgery, and delaying people having, side effects, which can be debilitating. But what we also know is that we're looking at being, less invasive to more invasive. The other treatment modalities other than the active surveillance is the brachytherapy. We still have external beam irradiation and surgery when we talk of low risk prostate cancer. So with brachytherapy, I think one has to decide, what is important, because if someone has got a big gland, that becomes an issue. On follow-up, the what you call the bounce phenomenon, it's another thing which I see patients, being worried about, and patients don't like being in the hospital for long. That is the other thing. So basically, when we are choosing between brachy and what I also realize is that with brachy, most of the time is you'll put the seeds, do a CT scan after, so that we can be able to see if the seeds are well, in the right position. Problems that, with it as well is that if someone has been having erectile dysfunction before, even post brachy, obviously they'll still have a problem. Some of the things that people get concerned with any of the treatment that we give, I like talking about, PPC as a mnemonic for that, even when I'm teaching my undergraduate, that what, we always think of potency, we think of patency, and we're thinking of continence. But what I also should mention is that if someone has got, lower urinary tract symptoms, offering them brachytherapy becomes an issue, because especially if your IPSS score is, above 16, for instance, because the likelihood of retention is very high. So some of the important things that we look at, especially now when I'm treating, a lot of private patients, is to see that the cost becomes an issue when we're on any type of treatment that we offer the patient. Of course, age is important. The pre-existing, as we talked, what are their preferences? Then you can decide on that. The issue of radical, I should say, in the past 3 years with the robotic, South Africa will be having robotic, option. I've seen many patients rather go for radical prostatectomy robotic, okay? So with radiation therapy, external beam usually now, it's actually done most of the time being combined, being a dual, modality where we'll put the peripheral seeds of brachytherapy and then do external beam. With the low risk prostate cancer, brachytherapy is the way. And most of the cases we do use the low dose type, where palladium is used. Combination therapy is usually for intermediate and high, where you have to decide whether it's dual or you have got to add androgen deprivation therapy. Then watchful waiting, I've already talked about. What about focal therapy? Actually now here at the SIU, I've attended some of the interesting sessions on focal therapy, with your cryo, with HIFU. It's something that I can see that is getting, a big space in the treatment of prostate cancer. And it actually looks very, very interesting. As we're talking, let me just talk to you about some of the cases I wanted to share with you. I'm gonna try and open this up, because this is one of the cases that I had not long. So just to share with you practically with cases that we have. This is actually an imaging that I did. It's a 42-year-old man, whose PSA was on average initially it was 2.5, it went to 3, and then 3.5, and then it remained there with the general practitioner. So the general practitioner decided to refer him to me. Being 42, he had a strong family history of prostate cancer. His father had prostate cancer, and his uncle, and early, one in early 60s, one in 50. So I saw him as a high risk But on the MRI, initially I gave him, obviously, which is what I like doing, giving anticholinergic, giving them something like Flomax, for instance, and saying to him, you know what, let's check your PSA again after 6 weeks, just to be sure that it's not prostatitis. When he came back, the PSA was still 3.6. So I decided to do this. And most of the time, so I want you to just see, because I just put the image in there, but I want you to see the report where it actually, no areas of restriction or that is indication of malignancy, but there's a small lesion in the central zone next to the ureter, probably benign pyrus 2. So that was the report, you know, that I got about him. So I want to know, would you have biopsied this patient or not? Because we know when you are using the pyrus score, usually from 4, the 4 and 5 is when you get really worried. Anyway, in this case, because he was, I did this, you know, usually they'll come in the hospital, I'll do the MRI, already they're on the list for a biopsy, and he's already prepared for a biopsy. I continued on doing the biopsy. And interestingly, the results, when they came, it was a Gleason 3+3. So now what do I do? That was the issue that I had now. Do I follow him up and not do much, or do I do something on, do I act on this? The clinical exam is a T1. PSA, like I said, is 3.6. I decided to do genetic profiling, and which is another challenge. I'm just now talking with you about practical things. The ones that I did was the BRCA genes, the BRCA 1 and 2, because of the cost. That's one thing which I also, because the pathologists, I remember them calling me, okay, which ones do you want? Because this can actually easily exceed more than 10,000 rands if you want to do all the genetic. Because at present, that's what I want to also mention, is that you find that the genetic profiling, it's there, but it's more on, you know, trials than anything else. Because in practical terms, we do say that the cost already has had an MRI, has had a biopsy, you do and then after all this, honestly, even now we are doing the PSA. I saw him first time in 2018. The PSA has never gone up. He's still on the same. So this is just one of the cases that I wanted to share with you, to show you that sometimes you find that we did, but at least he is relaxed because he knows we have, you know, left no stone unturned, and basically there's not much, you know, to worry about, and we are following him. Luckily, even if though, like now, because initially I was doing 3 monthly follow-up with him, now it's 6 months, although sometimes you find that it doesn't turn up, but he'll do the PSA. So that is, and when he comes, rectal examination to check him and see what is going on, or if I can feel anything that is different. So the issue is that active surveillance is a viable management option, you know, and it actually works. In this study, they mentioned that it can work even in more than, you know, 50% of newly diagnosed prostate cancer. So the issue which I want us to be aware of is that thing of saying once a cancer, you know, is always a cancer. No, we have got options that we can have where we can have someone on active surveillance, and then we can easily move them, you know, to active therapy if there's anything clinical, especially if you've got a compliant patient. And then from there, you can decide on following them up post-therapy to see, do they have any biochemical recurrence? And then, of course, you can work with your patient if at some point they need any hormonal. So it's nice because we have got this tailored approach, you know, treatment for our patients. And I think that's how we should, you know, explain to them when they come. So what about the role of multiparametric MRI imaging? Because last we used to talk about endorectal, but now we know that no, it can be done. It can show. And there are some patients who you find that you didn't do an MRI before biopsy. You can still do it after the biopsy. to be able to stratify and follow up your patient who is on active surveillance. And then let me talk about this case 2, which I had as well recently, who I ended up doing brachytherapy. 65 years old with lower urinary tract symptoms, which were moderate, about IPSS of 12. He had inguinal hernia, which was a direct and reducible, PSA of 6. So I decided that no, we are going to do, he was actually on Flomax, and then I decided, no, let me, because I've been following him up for years for BPH with a PSA which was less than 2, and then it increased to 6. I decided, no, let's then go, we'll do TURP, and we'll also do biopsy for you. And then this is what we found on the infiltrating, but this was a glycine 7, 3+4, and clinically it was a T1, basically. So with discussion with him with the low PSA, we opted on for brachytherapy. Why is brachytherapy one of the treatment options that we have? Because it's relatively, minimally invasive for the patient, can be done as an outpatient with minimal side effects. So, since the procedure has been fine, but I think also the minimal TURP, especially for the lower urinary tract symptoms, is one of the good options, for some of these patients. And the last case that I want to show you is the patient with 56 years old who had a PSA as well of about 7. And then I did a biopsy which showed that no, he actually had it was also glycine 7, but he opted for a radical prostatectomy. You will see that these patients are almost having similar disease profile, but the choice when you discuss with the patient may be different. That's why I'm mentioning the issue of a patient-centered approach. He decided, no, I would want to have a radical prostatectomy, and there was no upgrading on the percentage of the prostate involved, less than 0.3%. And after this procedure, he actually, had incontinence, in the first few months, and he had severe erectile dysfunction. So basically, this is one of the newer, the International Society of Urinary Pathology, where they talk about what are the things that we should look at on the specimen, the prostate, after you have taken it out. On the monitoring of this patient, this is just to show you the PSA, profile throughout. You can see that it has been fine, but he was coming to see me because he can't get erection. I gave him Cialis, sildenafil. He was not responding to sildenafil. We ended up now succeeding with Caverject. You can imagine he's 56. He came with his young wife who was not looking at me well. I could see that she was very angry. So, but the issue is he had both incontinence, which responded, because after a few months, pelvic floor muscle exercises, he was okay. But the impotence is now basically dependent on Caverject for that. So with radical prostatectomy, there are advantages and there are disadvantages. And the issue is most people would always be saying that, no, at least the prostate is all out. But at present we are looking also at what cost is it out? And that is very important to discuss this with our patient. What about focal therapy? I personally do not have experience of doing focal therapy, but like I'm saying, I'm warming up to this idea that, okay, if it's part of the prostate that is diseased, why are you removing the whole prostate? What are the things that you can do to offer me solution without giving me too much side effects? And I think these are some of the things that we need to come up with as clinicians to find ways of still continuing to offer tailored approach to our patients. And like I said, we are looking at cats in different groups. You don't want to end up, with a low-risk patient over-treating them, and then a high-risk patient under-treating them. So getting the balance of this is one of the big things that on a daily practice, we have to make choices and decisions. And I think you having things like adding MRI on board. And I hope the issue of biomarkers and of genetics will add, some kind of, easy way to make decisions so that we don't overtreat or undertreat. Thank you.
Thank you very much. That was really great. And really appreciate the cases, the examples that you gave. Oops, my video is still not on. There we go. I am looking for some questions in the chat, or I don't know if anyone else has some questions. I do have, a very practical question about how you think, patients really tolerate the active surveillance or the watchful waiting from an emotional standpoint. Do you find sometimes patients just that every 3-month PSA causes so much anxiety that they choose another path?
I actually, I'm thinking first of myself. How do I deal with it? That someone has to do blood, and for some of them, I have to remind them, like, because you end up knowing them literally by first name, because they're seeing you every often. That's why what I've seen is, even if you don't come, please just do your PSA, and then some of them will, at least twice a year makes more sense to them. But anxiety is one of the reasons where you find that they've been in that urologist, they come to me. That's one thing which I've observed, that they left another urologist, they come to me. And then I'm sure that some of those that I see, they go to another urologist. So I think there's also a lot of, movement. You think your patient is not compliant when they actually got treated by somebody. So I think in our space, there's still that thing that I've got cancer. So the anxiety is still there. And like I'm saying, it's something which even us as clinicians, we didn't have, because what we always saw was metastatic. So when somebody comes with local, we're like, yo, finally someone came in, I need to do something, like a knee jerk. So, but now compliance is very important, and understanding when you have a patient who can understand. But honestly, it's not an easy, it's not an easy plateau for us as well, yeah. I don't know how it is in your space.
Yeah.
But, yeah.
I see a hand up with another question. Dr. Justine Royal from Aberdeen.
So lovely talk. Thanks very much, Dr. Bashaka. That was really, it's nice to hear that in South Africa, on the other side of the world, things are so very similar to what they are in Scotland. The one difference actually from your talk, was what I wanted to ask the question about. So our brachytherapists wouldn't touch anybody after a TURP because of the difficulties with dosimetry, but you've clearly tackled that. And I see there was another question in the chat about that. How did you what sort of modifications do you do to try and deal with those?
We're saying your brachytherapists wouldn't do,
They wouldn't go near anybody post TURP.
Oh, no. With us, there are patients who will do minimal, TRP, like I didn't show you the number of, the amount of grams in the other, it's around 8 grams that we take out. And then we wait 3 months. After 3 months, we go in and then we will put in the seeds. So they have warmed up to that, a lot. You know why? Most of our patients have got big prostates. So I think otherwise brachy would never even be feasible. So, and one of the things which is very interesting is that most have got big prostates, and I see a lot of prostatitis as well, where we get, and I've come across even prostate abscesses when I'm doing the TUR. And then after that, you find that the PSA goes down. So it's an option. I think for now, I've had more than 10 patients who I went that route.
Thanks. There's one more question. I think someone has typed but it's just privately to me by mistake. So it just said, what time would you give between prostate biopsy and then a repeat MRI to reduce the artifacts reported as a lesion? So that's Dr. Odutola.
Yes, yeah. You know, I actually used to go for 3 months, but we actually in South Africa, you know, there are some sites where they were checking this thing of artifact, but 6 weeks is usually fine for artifacts of hematoma. You don't have to wait, you know, 6 months like I used to think. No.
Okay.
So 6 weeks works.
6 weeks, great. And Justine, would you have any comment on that? Is it a reasonable time frame?
Yeah, I mean that's certainly what our guys who do the multiparametric MRIs, they like 6 weeks. I think you can still see some hemorrhage at that point, but it's not the end of the world, and there's enough differentiation at that stage that it's okay for most patients.
And
yeah, and I see someone who have commented with large prostate volumes, we can do 6 month hormone treatment for patients who absolutely want to have brachytherapy. And I'm thinking, usually when we do brachy or when we do surgery, these are patients who want to have the erection, you know. And what I've learned is when you give any hormone treatment, even if you can give 1 injection, the impact can go on more than a year, you know, with that testosterone being low. So one of the reasons with local treatment is to try and defer ADT as much as possible, unless if it's a high-risk disease. So I usually refrain from just giving hormone treatment for, you know, shrinking the prostate. Yeah.
great, fantastic.
Great, thank you.
Thank you very much for wonderful.
Thank you very much. That was just really wonderful. Great conversations there too. So I think now Madina Ndoye, Dr. Ndoye will introduce the final speaker.
Yes, I could invite my
You will.
colleagues.
Okay.
That's great. So yeah, it's been really exciting to invite one of my very respected senior colleagues in the region of Scotland, Dr. Justine Royal. She has been a huge inspiration for all of us, not just women in urology, but for men in urology as well in our region. She graduated from Medical University in Manchester and then completed her training in urology in the Scotland region. And following that, her area of interest is pelvic oncology, with more focus on prostate cancer, and has been among the pioneers of robotic prostatectomy within Scotland over the years. More than that, her role has been of trainer and educator in the region as well, and she has served as Associate Dean for University of Aberdeen as Training Program Director for Scotland region. And I didn't train in this region, but ever since I was joined as a consultant, always the trainees, the residents who have trained here have spoken very high about their time with her being a Training Program Director. And one of the very exciting news, which is fresh, is that after serving a few years on the Specialist Advisory Committee of United Kingdom, which guides and regulates the training of urology across the country, she has now been appointed as the chair for that, which is going to be very, very useful for the training in the country. And I would like to invite her for a talk on advanced, locally advanced and high-risk prostate cancer.
Thanks, Ishan. I'm going to try and share my presentation with you. Hopefully it will work. Can you see that?
No, it's still, I think, sharing screen.
Okay. Can you see that okay?
Yes, yeah. Yeah, it's good.
Excellent. Okay. Let's see. Right. So many thanks for inviting me to talk, Zishan, about high risk and locally advanced prostate cancer. Living in Scotland, I'm going to, I'm afraid, give you a very Scotland-centric view. So that's the aerial view I would like to pretend from Aberdeen Beach. My disclosures, so I've had speaker fees from a number of medical corporations, but the one that I would really have to declare is that I'm really in love with my Da Vinci system. I've definitely taken to robotic surgery and never want to go back ever again. So I've been asked to talk about high-risk prostate cancer, and using the EAU definition, which I think is probably what most of us would go to, certainly in Europe. We have actually got quite a large heterogeneous group in the high-risk area. So it's any PSA greater than 20, any ISUP score 4 or 5, or Gleason 8, 9 or 10 in old money, and anything which is T2C or above. But of course that also incorporates T3 and T4 disease, and are also locally advanced disease, which by definition is node positive. So as it's a very heterogeneous group, the prognosis is also very variable. Looking at studies, the long-term survival can be as low as 30 to 35% at 5 years for locally advanced disease, T4 with node positive, but also in our high-risk disease where we're talking about Gleason 8, but organ confined, obviously we can see survivals up to 80 to 90% disease-specific survival at 5 years. So it's a very heterogeneous group, and I would encourage people to think about the patient and go for the patient-centered approach, as the previous speaker was saying, because it's not one size fits all. So in terms of staging for our prostate cancer, routine practice in the UK, and I think most of Europe, is to do local staging in the form of a multi-parametric MRI scan. Most of us these days would do this prior to biopsy, just to prevent the delays in staging afterwards. So it is quite useful to give us local staging prior to a biopsy. Our local practice is also to perform a bone scan in high-risk disease. So only high-risk disease, we'd also do a bone scan. And we'd also do a CT chest, abdo, pelvis in high-risk patients, basically to make sure that we've got the staging right. It's interesting to hear that in South Africa, you've obviously got good access to PSMA PET, which certainly in Scotland is what we would like to have. And I think it's a perfectly good substitute to have a PSMA PET in place of both the bone scan and the CT chest, abdo, pelvis in the high-risk patient, because actually in terms of accuracy, in terms of staging, the PSMA PET is definitely, I think, superior to both bone scan and CT scan combined. And that will be the direction of travel. And I think a lot of units across the world have moved in that direction already. So what are our options in localized high-risk prostate cancer? So this is our gentleman who comes to see us with a PSA of greater than 20. He's got a Gleason 8, 9 or 10, but his staging investigations have shown organ confined disease. Okay, so he's got T2 or less with no obvious nodes on his staging investigation. So what can we offer him? We can offer him a variety of things, but one of the most important things to think about when we're counseling these patients is the risk that we're not going to cure them. I've said that there's already a high risk of recurrence, so we need to think in this particular population that the recurrence rate is going to be between 30 and 40% in terms of biochemical recurrence, certainly, even if we don't see evidence of physical recurrence. So they are at high risk of running into problems, particularly if they're in the younger age group. And part of the counselling process in these men is preparing them for that, and preparing them for the fact that their first treatment may not be their only treatment. Clearly we'd like it to be their only treatment, but it may not be the case. So it's very important that they think about the possibilities. So in terms of counselling, certainly when we're counselling our patients, we would offer them radical prostatectomy, which I think is a perfectly reasonable option in these gentlemen. We'd also offer them radical radiotherapy. We would always, in the high risk setting, unless there was a very significant cardiovascular risk, offer neoadjuvant hormone manipulation, which would usually continue on for 3 years, and we'd usually give around about 78 gray. Elsewhere in the UK and certainly across Europe, they use brachyboost with external beam radiation. If the urinary function is good, and that could then potentially drop the neoadjuvant hormone situation down to 2 years rather than 3. But I think the most important thing here is to think about the multimodality treatment for these patients being a possibility. So suppose they choose a radical prostatectomy. What sort of considerations should we make when we're planning their surgery? In our unit, as I'm sure in most, we use the Briganti normogram to determine possibility of lymph node involvement, and we do an extended pelvic lymph node dissection in all patients who have a risk factor that is greater than 5% for involvement. Now, almost by definition, everybody in the high risk group is therefore going to need an extended pelvic lymph node dissection. Patients need to be counselled quite carefully, and we do involve them in the attendant risks of extended pelvic lymph node dissection. So we have a lymphocyl rate of the order of about 0.5% with an infection rate of about 0.25%, which can sometimes necessitate a trip back to theatre, particularly if the infected lymphocyl is very close to the vessels and patients can't be drained radiologically. So I think it's important that you point this out to patients when you're talking about their risk, because obviously if you're performing an extended pelvic lymph node dissection, they need to understand that this is really not being done in terms of their prognosis, because we know that there probably is no increase in survival benefit with a pelvic lymph node dissection, but what it does offer is accurate staging, something that is really important in terms of planning future treatment for these patients. We would always offer a robotic approach. Very rarely we would have to convert if patients have had previous extensive pelvic surgery. Usually anterior resections or meshes inserted can cause us some problems, but we would usually always persevere and go for a robotic approach. The vast majority of Gleason 8, 9, 10s, we would not offer a nerve sparing procedure, just because we will be more concerned about micrometastatic disease that we hadn't picked up on the scan that might be better cleared by doing a more wide local approach. Very rarely, if we've got consistency between our multiparametric MRI and our biopsy and our clinical examination under an anaesthetic, we might consider a unilateral nerve spare if there's absolutely no evidence of disease on one side, but that would be on a rare occasion and on quite an extensive discussion with the patient. What about patients who we know have locally advanced disease? So if a patient has T3 disease on their MRI scan, what can we offer these guys? So obviously, by definition, anything that is just going to be treating the gland itself is not going to be helpful, because that area out with the gland is not going to be treated well. So we usually would not be offering these patients brachytherapy. We would be giving them a straightforward choice between radical prostatectomy with extended pelvic lymph node dissection with the discussions that we've just talked about, versus intensity modulated radiotherapy with 3 years of androgen deprivation. Clearly, depending upon how the patient feels about these things, we'd also be counselling them regarding their risk that they might need multimodality treatment. We would counsel them that the cure rate is similar but not the same. There is a slight survival or disease-specific survival advantage to IMRT in most studies, but it is a couple of percentage points. So what we actually counsel our patients is that, particularly if they're young and contemplating multimodality treatment, certainly in our hands, the morbidity of having a radical prostatectomy first, then followed by radiotherapy, is less than if we go the other way around. And certainly in our younger population, we counsel quite strongly to consider these things. We do explain to them that we're all extremely pessimistic for the amount of time that we spend dealing with our cancer patients, but and that their cure rate is still reasonable with T3 disease at around 60 to 65%, but they may want to think about having their contingency plan in place. So what about the timing of multimodality treatment? Well, obviously there are two options. You can go straight in with immediate second line treatment, or you can consider salvage treatment. So what sort of things will help us decide whether we should go straight for adjuvant treatment or not? So one of the guidelines from the EAU is that if we have up to 3 high-risk features in our post-radical prostatectomy patients, we should consider immediate adjuvant radiotherapy. So this is patients, again, by definition in our high-risk group anyway, but with the addition of positive surgical margins. Certainly in our hands, we actually have taken a more expectant approach. We enrolled a lot of patients in the radical study, which looked at the timing of adjuvant radiotherapy. And coming out of the radical study, the vast majority of the time these days, we actually tend to wait to see if we've got biochemical recurrence prior to offering adjuvant radiotherapy. What about patients with node-positive disease? What should we do with those? Because obviously they're then in a very different position to our patients who we know have had a nodal dissection and haven't had any evidence of nodal involvement. Well, we can be in 3 situations here. We can have evidence that they have biochemical recurrence or biochemical residual disease, sorry, I should say, post-prostatectomy. And I think if that's the case, it's perfectly reasonable at that stage to offer adjuvant radiotherapy. Our practice these days is much more commonly to consider adjuvant radiotherapy plus additional intensity modulated radiotherapy to the pelvis, both the prostate bed, depending upon the risk factors that have previously been mentioned in terms of positive surgical margin, and with a boost to the lymph nodes. The third category to consider would be the gentleman who's had a good lymph node dissection, that the disease is confined within the node, it's not breached the capsule, and when you do his PSA at 6 weeks, it's actually less than 0.025. Most of those patients in our practice we would manage with an expectant approach. We would monitor their PSA quite closely. We would counsel them that they are at risk because of their node-positive disease. But rather than giving them the morbidity of androgen deprivation early on, we would actually wait and follow their PSA carefully and see what happens to them over time. And I think that does offer significant advantages to the patients because it allows them to not have the side effect profile that androgen deprivation gives them. What about post-treatment recurrence? So obviously we're now talking about the salvage setting, so we're waiting for our patients to manifest evidence of disease. So with these patients, it's important to think about the timing of recurrence, whether it's within the first year or whether it's 3 or 4 years down the line, influences whether this is likely to be micrometastatic disease or whether this is likely to be local disease. PSA dynamics are again incredibly useful in terms of guiding where this disease might be. Clearly, if they've had a radical prostatectomy, allowing us to find out if they've got node-positive disease is incredibly useful. Equally, it's very useful to know if they had node-negative disease. And the advent of PSMA PET is incredibly useful. We tend to reserve PSMA PET for patients with a PSA greater than 0.2 because obviously the diagnostic accuracy improves at this stage. And if the PSMA PET is negative, that's actually quite a useful thing because that can help to guide your treatment options following your first line of treatment. So let's think about our patient post-prostatectomy with a PSMA recurrence. What should we do for him? I've already said that considering a PSMA PET will be incredibly useful. And if this doesn't show any evidence of metastatic disease, you can then go on and give salvage radiation to the prostate bed. We would usually offer hormonal therapy, but not mandate it, depending upon the risk factors and the profile of the patient, particularly if they've got high-risk cardiovascular disease, we may well omit the hormone therapy in this stage. And from my perspective, I would like them to have at least 6 months post-radiotherapy, post-surgery before radiotherapy, and that we know improves their outcome in terms of continence and erectile dysfunction and problems with rectal dysfunction as well. So all these things sway us towards waiting for a PSA recurrence prior to treating them rather than going for immediate treatment with radiotherapy in the salvage setting. So what are our post-surgery recurrence options? Obviously, we can offer them radiotherapy to the prostate bed with or without androgen deprivation with boost to the nodes, and we're increasingly doing that these days. What about if we see on our PSMA PET an isolated low volume recurrence or an isolated MET? We're increasingly using SABR for these, particularly if it's one or if it's very low volume. We would usually consider that as a package of care with at least a period of androgen deprivation, and we may or may not also offer the patient systemic therapy. We would particularly use that if there is evidence of high volume or high volume metastatic disease, so larger than 4. We would consider intensification of systemic therapy with either abiraterone in our practice, or more commonly in the rest of the UK, enzalutamide is often used. What about our post-radiotherapy recurrence? So it will be our practice, if the patient is physically fit enough for salvage therapy, that we would go ahead and image the prostate using a multiparametric MRI. This would then allow us to localize the abnormal areas, and depending upon where these were sited, we will either do a conventional or a fusion biopsy to allow us to accurately gain what's the information about what type of disease the patient has recurrently. We'd be quite keen in this setting to get a PSMA PET prior to any salvage treatment. We have substituted when we've not been able to get PSMA PET, choline PET, but this is really only shown to be very useful in our patients when the PSA is over 1, which most of the post-radiotherapy recurrences are by definition. So we would use both PSMA PET and a biopsy to guide our treatment. So what are our options in terms of treatment for these patients? We could offer them salvage surgery because most of our patients have come through our unit first. So all of our patients are counselled by a urologist, usually with an interest in prostate cancer, prior to meeting a radiotherapist. So it would be unusual for them to have not been offered surgery first anyway. So we don't see many for salvage surgery, but certainly salvage surgery post-radiotherapy is an option. The main problems with it are the high risk of not curing the patient, and we know from large longitudinal studies that this is often the case, and the very high risk of morbidity and mortality, almost a 10-fold increase compared with de novo surgery in terms of fistula formation and incontinence. More commonly in Aberdeen, we would be offering patients focal therapy. We would be involving them in trials such as cryotherapy for patients that have had recurrent disease. Clearly, this is only suitable for patients who have T2 disease on their initial staging. Anybody who's got T3 or above, focal therapy is not an option because it's not going to cure them. So these people who are maybe not suitable for salvage surgery or salvage focal therapy, we're then looking at systemic disease and the timing of systemic treatment and the timing thereof. So we would use androgen deprivation, but we'd only do that if we see evidence of metastatic disease on either the PSMA PET or if their PSA is high enough on conventional imaging. We certainly wouldn't start systemic treatment without that. That can be a very uncomfortable position for the patient to be in because obviously they're watching their PSA rise. They know they've got disease somewhere, and that can be a very hard psychological impact on them. And we quite often involve our psychology services at that stage because it can be a very difficult and tricky thing for patients and their relatives. What about locally advanced node-positive disease? Our practice in Aberdeen, particularly if there's no nodes above the pelvic brim, would be to treat the primary. Again, we're going for a multimodality approach here, so we would usually always use radiotherapy rather than surgery unless there were patient factors which meant that surgery was going to be that radiotherapy was going to be difficult, such as colitis or Crohn's, then we may consider a basically tumor debulking radical prostatectomy and pelvic lymph node dissection. But our go-to for locally advanced disease with nodes in the pelvis only would be radical radiotherapy with neoadjuvant and adjuvant hormones for 3 years with a boost to the pelvic nodes. We might also well consider, if the patient is fit, intensification of our systemic therapy in the form of abiraterone, most commonly in Aberdeen, but certainly elsewhere in the UK, enzalutamide is used in this setting. We've also, prior to COVID, which obviously had an impact on how we've managed all our prostate cancer, also used docetaxel in this setting for the intensification of systemic therapy to improve the prognosis long term. But clearly these are a different cohort of patients if we know that they're node positive on imaging prior to planning their systemic treatment. So from what I've just said, obviously radiotherapy may be superior to radical prostatectomy and extended pelvic lymph node dissection. I think this is particularly true because radiotherapy has the ability to treat the micrometastatic disease that I can't remove with my lovely robot, and I think that extra boost to the nodes, which occasionally slips above the iliac brim, is actually quite useful in these patients, because if they have got nodal disease that's extended up the iliac chain, it is quite likely that some of them will then represent with disease in the retroperitoneum, and certainly that we have started thinking about boosting these patients with a dose to the retroperitoneum as well at the same time as treating their pelvic disease. So in summary, I think the thing that I would like everybody to take home tonight is when they see these patients, some of which have a really poor prognosis and are going to die from their prostate cancer, is to think about multimodality treatment, and that there is always more than one way to skin a rabbit, by which I mean there's always more than one way to deal with somebody's prostate cancer. Thank you.
Thank you very much, for a very, very comprehensive, interesting, and a thorough talk. Any questions from anyone? Any of my colleagues?
I did see a question about SABR, that there was confusion as to what that was. Maybe you want to explain that a little further? There was a little discussion in the chat, but
yeah, the person who's put it stereotactic ablative radiation is absolutely right.
What happened here? Hi, is the system being stuck or something? Can you hear us?
I can hear you, Zishan. Yeah, I'm good.
Yeah, great.
I can hear you. Can you hear me?
Yep. I think the question's been answered in the chat in that it's stereotactic ablative radiation.
I had also asked a question.
Yes, please, go ahead.
Yes, yeah, I wanted to know, I mean, that was a great talk, Justin, very nice and quite extensive. I wanted to find out, you know, if you do sometimes use the nomograms, and if so, which ones do you use? The nomograms.
For
before surgery, yeah.
Before surgery, we tend to use Briganti, to be honest with you.
Okay.
Hi, thank you very much. This was a great talk. I just want to ask one question about patient quality of life while on AD2 treatment, and thus for 3 years now. How do you deal with ED in this case? And what is the best approach for you to mitigate the side effects of the treatment. And just after they did the ADT treatment, how did they recover their erectile function?
So I think that's an interesting question, because that seems to be one thing that's different across the world. And I have to say, in Scotland, it is unusual for our gentlemen who are on ADT to want their erectile function sorted. We do have the problem afterwards, and it is a big issue for them, but they don't seem to be as keen. We do have a few who want it treated, and I have to say the vast majority of the time, rather than going for a PDE5 or something like that, I go straight for a pump or Cabajet, because it's much more likely to be successful. It's more invasive, obviously, but I think the patients who are on ADT who want their erectile function sorted out tend to be the ones that are motivated to do it. In terms of afterwards, again, the erectile function return following radiotherapy and 3 years of ADT is absolutely pants, is the only way I could describe it. We have very few patients who are successful with the return of erections following 3 years of ADT and radiotherapy. 1 or 2, but again, the motivated ones usually that have been using the pump or Cabajet during their treatment.
And how much doses of Cabajet do you use?
We'd usually use up to 40,
40?
depending on dose response. Yeah.
You don't go above?
Not usually. We'd usually switch them over to the pump if we were really going for 40 and there was nothing at all.
There's one more question by Dr. that how does the nomogram influence the management of this subset of patients or in patient management as a whole? Question for Justine or Evelyn.
Yeah, so I think we use normograms in our counselling in terms of their risk of recurrent disease when we're trying to talk to them about multimodality treatment. I think they're quite useful because it explains, particularly to the more articulate patients that are able to take the information in, about how likely they are to get recurrent disease and how important it is to consider multimodality treatment. So that those risk predictors are actually quite a useful thing. I think for some patients, however, it's not useful. So for the average guy who's maybe come from Peter Ed fisheries, who's not the brightest chap in the world, you know what, it's not going to help him out. But for the articulate gentleman with a nasty high risk disease, going through the normograms prior to any treatment option is really useful.
Just one more question. We are aware of the timings to Madina, and I can see Professor Niang and Mohammed in the chat box as well. What is the PSA screening trend in Senegal and neighboring West Africa, and are we catching cancers earlier, prostate cancer? I know you guys have been doing a really exciting work with aortic and all other research bodies. Do you tend to see them in early stages, or it is more locally advanced or high risk?
You want me to speak, or I can let Professor Niang and Jalo Mohammed give that?
Yes, yeah, Professor Niang, please, or Mohammed, please step in. Right, okay. Yes, yeah.
Sorry, Zishan.
That's fine, Prof. Please go ahead. One of our very respected senior colleague in Senegal, Professor Niang, is with us as well.
Yes, I think now we see a lot of localized prostate cancer, but we still have a high burden disease. We still have a very aggressive tumor and high PSA at diagnostic.
At the advanced stage. And is multimodality management being introduced to some extent, as long as not metastatic, or?
Yes, metastatic. We have metastatic or very, very advanced disease, and now we do what we call multidisciplinary consultation. You know, with radiologists, with oncolog, with radiotherapy, and we choose the best way to treat them. And sometimes it's a multimodality therapy.
Great, fine. So I think it's moving in the right direction, which is so encouraging to hear. Thanks, Prof. Enjoy Dubai.
Thank you so much.
A little comment on that addition is you raised a very, very interesting point about the screening of prostate cancer in Senegal. Unfortunately here, men usually don't go to see their urologist, as a female go for the gynecologist. And we just passed from the October event where all the cancer of women are screened, the breast and also the cervical cancer. So for the whole month of October, there were many spots where women can go and get screened for free. But for November, the month for men, we don't hear anything about that. So I think that we need to move, to shake them, so they will be able to focus more on their health and come for a screening more earlier.
Right, okay.
It's a matter of education, I think, and we need to do more.
Yeah, certainly. And I think it is probably one of those things which could be discussed as a separate session in one of the WACs, isn't it? Just to first kind of increase the awareness within the urology itself practicing, and then the population in general. Yeah, great. Thank you very much.
Let me just comment on that. In South Africa, we had such screening programs, and we realized we cannot cope. So we don't do screening programs now. It's more of a patient-driven screening because there are not enough urologists or clinics to deal with the patients. So we don't stop teaching people, about taking care of themselves, but we don't do any programs because there are few people who can deal with, that's one thing which we observed with health education and awareness. So I just want you to be aware of that once the patient starts driving it, you need to have resources to be compatible to deal with the demand.
That's a very important thing to say, a very important point. Yeah. So, yeah, Suzette, would you like to make any concluding comments, please?
Sure. Yeah, this was really a wonderful opportunity. We heard from 4 outstanding urologic oncologists today. I'll point out again that all were female, so we're excited about that as well. Nothing against our male colleagues, but we're just excited when we can showcase our female colleagues and what they do too. And they were all from different parts of the world sharing their experiences and knowledge with us today. So just to recap, we first had Dr. Rana from Pakistan, who talked about high-risk non-muscle invasive bladder cancer, risk categorization for that, and looked at some patient selections concerning BCG use versus immediate radical cystectomy, non-surgical treatments for BCG failure, especially like immune cell checkpoint therapies. And we had Dr. Amin Smith from Johns Hopkins in the United States, and she spoke about muscle invasive bladder cancer, the role of organ preservation in muscle invasive bladder cancer, the limitations that we currently have of our current staging, and then how to pick the best candidates with that limitations in mind for bladder preservation. And then also look at some of the biomarkers that are coming down the pike. Hopefully you can still hear me. I'm not getting kicked out. Dr. Evelyn Mushakoa from South Africa then talked about prostate cancer, and again, patient-centered approach to low-risk prostate cancer, looking at a variety of algorithms, and then gave some nice case presentations and how she thinks about the patients to get the right therapy for them. And then last, Dr. Justine Royal from Aberdeen, UK, looking at high risk locally advanced prostate cancer, multimodality treatment for that. What does that mean? What does that include? And when do we use it? When is it most beneficial for the patients? And then again, looking at other intensifying systemic types of therapy for especially node positive disease, some of the things coming down the pike too. So thank you to all of our speakers. And I also wanted to say thank you again to Dr. Zishan Aslam for spearheading this program, and to Dr. Madina Ndoye for my co-moderator for inviting me to speak and participate in this as well. Thanks.
Yes, thank you very much, Dr. Sutherland, Madina, and all the 4 speakers. That's been absolutely fantastic. And it's great to hear all the magic work our female colleagues are doing all over the globe. And I would really hope that everybody enjoyed this, and we can do some more sessions on that in coming weeks as well, just to create a whole series of that. I would really hope, and would continue with the support from our colleagues.
Thank you.
Thank you very much.
To Justine and Suzette for their support to make this happen. And we talk about a very interesting topic on cancer. And I was very pleased to have Kanta here. He is Senegalese he's from Senegal, and he's actually at Institut Gustave Roussy in Paris. And he actively participated to this meeting, which is very interesting because we tend to go more for a multimodality therapy, which means that we will have to collaborate more with radiotherapists. And I would like to mention that in Senegal, we are making great effort in acquiring many radiotherapeutic machine, but we need to do more for screening machine like PET scan, because we didn't have it yet, but I think, or I hope that it will come soon. And as I earlier mentioned, the fact to educate patients is at the center of the care, and we need to educate them more and more to come earlier to see their physician. Thank you all for this excellent meeting, and I hope that the university program will move forward and go further. Thank you.
Thanks a lot. Take care and bye-bye.
Thank you. Thank you, everybody.
Thanks a lot. Bye.
Around the world.
Thank you.
Thank you.
Bye, Evelyn.
Bye, Evelyn. Bye.
Bye.